not going to try to redo surgery. What the point of our surgery lecture is because for PEDS surgery, there's a whole bunch of different diagnoses that you maybe just barely touch on. And so the point of this that I want you guys to do, again, can you recognize when I need to, what is the diagnosis? Can I recognize that it's a surgical issue? And then how do I get them prepped for surgery? Because the surgeons, if you remember, and you will see this in the hospital if you have not, surgeons do not want to do the medicine part of all of it. They just want to cut things, right? They are human beings that get paid for a living to cut other human beings open. It's wild to me, but that's what they want to do. So our job then is to work with the management before they actually go get cut. So can I recognize, make the diagnosis, manage them, get them prepped for the OR. So that is what we are trying to do today with these. We will just go till we want to stop. When you take a look at all of these, most of them are GI related. So functionally, what we're going to concentrate on today, and when we finish surgery on tomorrow, is going to be GI related issues. Are there thousands of other things that could be going on with a child that needs surgery? Absolutely. It's a total ortho world for PEDS. Most of these that we're going to talk about surgery specific are GI related. So, a couple of things in general to consider with surgery. In general, if you have a mom that has polyhydramnios, so too much fluid circulating, what it's telling you is that there is not that passageway, something is going wrong with the swallow and running through the GI tract, likely. It's not the only reason, it could be a mom reason, there's a lot of other things, but something to consider is there something wrong with this baby's GI tract where they are not able to continuously swallow this and continue to move it through? So that backup of fluid can show you a lot of things. So that's one thing to consider always. Thing two, if you have a delayed passage of meconium, it can often tell you, number one, am I missing some cells that are going to help move things along through, like Hirschsprung's disease? Or do I have something like cystic fibrosis? Those would be your other two main differentials for a delayed meconium. Anytime where you have an obstruction or a distension in a baby, you're supposed to have these big, soft little sourdough-like toad bellies. So a whole lot of times, if you were truly distended, you have an acute abdomen. Something is obstructed there, because we're going to talk about a bunch of reasons why little kids get obstructed. And then different vomiting. When you really look at this, there's going to be one thing. So that ligament treats, trites, and remember how to say it. Is it before or after that? Because depending on that, and then whatever that the infant vomiting looks like, is going to determine your anatomy. If it is above the ligament, it is going to be non-bilious emesis. If it is below, they are going to have the introduction of bile, so it will be bilious emesis. What color is bilious emesis? Green, like your bracelet. Like, hold that up. Yeah, it's like lime green. Like lime green. So bilious emesis, true bilious emesis is like neon green. Other considerations. How many of you had surgery before? Yep, we've had some surgeries in there. How comfortable is that where you're like, I'm going to be put to sleep and someone's going to cut me open and I hope everything's going well, right? Now, amplify that when it's happening to someone's child. Okay? So anytime you're telling a parent your child is going to need surgery, you just amplified that situation. So speaking human to people can be very, very helpful with very, very anxious and nervous parents whose child is going to be cut. So easy to understand terms will be super helpful, and some familiarity with what they're going to do, right? So if the surgeon's cutting and they're asking to their PCM or whoever what's going to happen, it's nice to have a general idea other than, I don't know, of what is going to happen to their child. Some of the questions will then have to do, particularly with kids, when can they go back to sports? When can they go back to ballet? When can they go back to whatever it is, going to school? And then really talking about why is it necessary. There's not a whole lot we do in pediatrics besides circumcision. It is elective, so really making sure that you have an understanding of why this is necessary, why we're telling these families you have to have surgery for your kid. So let's start at the top. So we're starting at the top of that GI, and we'll work our way down. So So esophageal, atresia, tracheoesophageal fistula. So start with that TE fistula. If we're thinking about this, I pull a lot of embryology into this lecture because it helps make sense of what's going on. I will just tell you right now, I'm not going to test the embryology of it, okay? I'm not going to test anything for that, but it's helpful to understand, I think, so take it or leave it. The trachea and the esophagus develop side by side, the very earliest parts in embryology, and then they split off and should have two separate tubes at that 4 to 6 week mark. So that's what should happen. When that doesn't happen, when you have some sort of abnormal formation in that very, very early age, very, very early stage, you potentially have this aberrant connection between your trachea and your esophagus. When you have that, that is functionally what a tracheoesophageal fistula is. They didn't finish fully separating. There's a lot of different ways that they can not fully finish separating. So the most common type is this type over here with your esophageal atresia and a distal TE fistula, right? So you have a functional blind pouch of your esophagus. So it ends and it goes to nothing. Okay? It goes to nothing, and then at the bottom, there's an aberrant connection to your trachea. Okay? So what happens when you try to feed this baby? It just comes right back up. You put it into a blind pouch, there's nowhere for it to go, they functionally immediately throw up. Do you get it into their lungs at all? They have to aspirate, right? If you feed them normally without aspirating, not really as much. What happens next door, where there's no TE fistula and they have this blind pouch and you try to feed them? Yep, same thing, absolutely, exactly the same thing. What about the H type? Yeah, they functionally aspirate each time, right? So do they immediately throw up? Nope, so they're not throwing up immediately because there is a full esophagus to go down into. However, there's that connection. So functionally, with every time they swallow, remember they're on this liquid diet, they can aspirate over into their trachea. So the H type, even though it's only 4%, is one of the favorite testable types. And one of those things you always look at because it's not immediately apparent at birth like you would with your distal TE fistula, but it's causing recurrent issues. So if you have a child, if you even have an adult, and you're like, man, it does not make sense why you just keep getting aspiration pneumonias out of nowhere. What are you doing? Like, are you trying to breathe your food? Functionally, if they have an H-type TE fistula, then yeah, that's exactly what's happening. More rare, the worst type would be that bottom type. So what's going to happen if you feed that bottom left type? Yeah, they immediately. They aspirate immediately. So you give them, they swallow it, and it immediately just goes into the trachea. So that is the worst type if you have that proximal TE fistula. So again, super rare, but that would be your worst type, those bottom two, right? Because you will have immediate aspiration in there, immediate choking, gagging, color change. So if that happens, do you just keep feeding this baby? Yeah, no, please don't do that. So immediately if you get that, hold off. So that is the different types of TE fistulas you will see. Most likely to see that blind pouch, most likely to be tested on your pants about the H type. So those are kind of the two that I typically will highlight. Oh, this is out of order. We already talked about the polyhydramnios. So sorry, don't know why I did that. But actually, I do know why I did that. I put that back in because this is a baby that if you didn't know, so you finally come out and you're like, oh, now I know what it was. If you look back in the records, they probably had a polyhydramnios if they had that blind pouch because there was nowhere for it to go. Now I remember why. So when this baby comes out, first thing is going to be this excessive drool. So let me back up that we're all talking about this first type. So common things being common, we're going with the 85% with your blind pouch. So excessive drooling, because there's nowhere for it to go down into the stomach or anywhere else. So then you also see that saliva bubbling there. Remember we talked about way back in block 1 that sometimes if you're doing an exam and you see that single umbilical artery, there's supposed to be 2. Some babies will just have one. This would be an example that just correlates with a TE fistula. So something to think about. If you saw that on exam, doesn't necessarily mean they have it, but if you saw that on exam and they started having recurrent, frequent aspiration pneumonias, something to be kind of under differential. TE fistula is also something associated with something called Bacterel. We'll talk about on the next slide. And certainly, if you have that immediate emesis, you have that immediate recurrent vomiting or respiratory distress, do not keep eating for that. So when I said we're going to talk about Bacterel, what kind of syndrome is that? So when we talked in the oncology lecture about that really kind of annoying syndrome of Wager syndrome, because you're like, Wilms tumor, aniridia, renal, like it was just all over the place, right? This is another one. So Bacterel is a little bit more common. However, it's a syndrome, it's a collection of things that you can't pin back to one single genetic abnormality, but that you see kind of they go together as a group. So when we're looking at Bacterel, the V is looking at some sort of vertebral anomaly. Maybe we're missing a spinous process. Maybe we're missing a whole vertebrae. Maybe we have a million different, butterfly vertebrae. There's a million different things that could be some sort of vertebral anomaly. Anal atresia. We'll talk about that here at the end, but you could have anal atresia where you have no functional exit. That would be one of the A's. Cardiac abnormalities can come in all shapes or sizes. Maybe this is a VSD. Maybe this is an ASD. Maybe this is dextrocardia. Some sort of cardiac abnormality. Your TE part is your tracheoesophageal fistula. So one of those types that you will see. Renal anomalies. Maybe this is a horseshoe kidney. Maybe this is a solitary kidney. Maybe this is polycystic kidney. Something is going on with the kidney. And then limb abnormalities. So I always say I had a couple of different patients over the years. So I had one who was missing a spinous process, had anal atresia, had dextrocardia, an H-type, had a horseshoe kidney, and had syndactyly. That was that patient. I had a whole other patient who didn't look anything like that, had one butterfly vertebrae, did not have anal atresia, had had a bicuspid aortic valve, a blind pouch, horseshoe kidney, I think, and then an extra finger. Right? So it can come in all these different ways, shapes, or sizes, but the point is they meet all of that criteria for Bacterel. So something, if you're trying to put together a whole bunch of random different physical characteristics that you can't put together, a good syndrome to think about. So for those common things being common, you have this baby that just threw up everywhere immediately after you tried to feed them. So it wasn't like they were calm for 5 minutes. This was like swallow, 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 it comes right back up at you. You try to put an OG tube or an NG tube, so I'm going to use those synonymously throughout this today, so you can either put it in their mouth or up through their nose and down. So put that catheter in, and you will see that it does not pass into the stomach. It just curls up in that blind pouch, or it comes right back up and out. So if you take an x-ray of that, you see it curled up in there, in that blind pouch. Then you're going to want your next step after trying that. So your first step, does it pass? Let's make sure it didn't pass. Next study that you're going to do is some sort of gastrographin swallow. And you want it to be water soluble. And make sure that if it goes into the lungs that you're okay there. Because that aspiration risk. So this would be an example. You tried to put that NG or OG tube down. You see it as a blind pouch. You see that that tip has nowhere else to go. So that's you functionally, from an x-ray, made your diagnosis of a TE fistula. Here would be your gastrographin study. So if you're looking, you see two tubes, your esophagus, your trachea. You should see gastrographin going all the way down your esophagus. You should see nothing in the trachea. However, we see it going all the way down the esophagus. We see the one little aberrant connection, and now we see the gastrographin into your trachea as well. So now we know we have an H-type in this particular example. This is what your next step would be. So that would be what your primary care PA is. I've assessed that this is not normal feeding, this is not a normal pattern. I have put an NG-OG tube in, it does not pass. I am going to take an x-ray. If I don't know what type it is still, I've ordered a gastrographin. Now I've made sure we're not feeding this baby, so there is some sort of IV access. And now I'm going to call a surgeon, because the surgeon is going to have to ligate that fistula and to make sure if there's a blind pouch somewhere that the esophagus is connected to the esophagus. Right? So that can be anywhere from a quick ligation of that H type to massive surgeries where they're trying to connect a large area, esophagus to esophagus. So can be a big thing that you see sometimes. You can see stenosis there. You can see it reopen after it's ligated. You can see a lot of problems with this. So best case scenario is that H type you can do a quick ligation of. Oftentimes that's not the case since it's more of a rarer type. One of the things that will happen is you've made that fake esophagus. So that's not, that fake kind of esophagus is not growing with the child. So oftentimes they will let the child do the first couple of years of growing and just have a G-tube for nutrition in, let them grow, and then go back and fix it later. So one of the problems with that is that you miss out on all of that normal development we talked about from block 1. So you're not getting a lot of that suck, swallow, breathe because you're not doing all of the normal feeding processes. Something to be aware of. Is there another example of that H type before and after weird like power stance of a baby? Never seen a baby do that, but just nice. So some of those complications I mentioned. So sometimes if you have that fake esophagus, there's poor motility in that. It can make reflux worse. You can anastomose at that site or have any kind of stricture there. If it's not a perfectly done anastomosis, you can have leakage there. The fistula can open up again. And then you can have, after it's been manipulated, the trachea, you can end up with some of that floppy, we talked about laryngomalacia, you can see tracheomalacia, that area has been manipulated, and some other respiratory type symptoms. Okay, let's move further down. So we started in the esophagus, we're moving down into the stomach. So pyloric stenosis, super interesting one because it's pretty common. It's one of the most common things that we see in PEDS surgery. Has anyone in this room, do you or your sibling, had pyloric stenosis? Anyone? So you're going to be the first class. So, dang it. This is the first class then. That somebody in the room, either themselves or one of their siblings, didn't have pyloric stenosis. So that's how common it is that most IPAP classes, somebody or their sibling has it. When you think about how common that is and who you see it in, for whatever reason, you typically see it in firstborn males. It's just the population that you typically see. And really what's happening is that pyloric muscle at the end of the stomach, for some unknown reason, is getting massive hypertrophy. So much so that there is outlet obstruction. So the food can get into the stomach and it can't get any further than that. So their number one cause of obstruction before that 3-month period of age. The typical presentation is then, they come out totally fine, healthy, happy, normal babies. They get to go home, they're doing well. They come back for their 3 to 5 day check, they're doing well. They have their 2-week visit. We're awesome, everything's fine. And then the wheels start to fall off the wagon. So that's typical presentation if you're thinking about a month of age. It's non-bilious emesis because they haven't passed that ligament yet. And functionally, they are starving little babies. They're so hungry. I eat this whole amount. I'm satisfied for just a second, and then I throw everything back up. So when they say projectile vomiting, so most people think projectile vomiting as forceful vomiting. Right? So if you've been around a baby, when you have a baby throw up most of the time, they just kind of upchuck, they look at you and laugh, and it's just kind of all over them and their car seat and the diaper bag and everywhere else in the car. That's most of the time. When parents are saying this child had projectile vomiting, what most parents mean is that they had forceful vomiting. So I'm talking about like this kid threw up from me to right here on the table. That's what most parents mean when they're like, this kid had projectile vomiting. When you have a pyloric stenosis kid, that pylorus is so hypertrophied that it's true projectile vomiting, meaning they could probably hit the 3rd row. They could hit across the room. Right? If you're in a room with them, in an exam room, they could hit the door. Right? That is a true projectile vomit, is how much force is behind this. So the board question truly gives you projectile vomiting, that word, it means like not here, 3rd row. The infant is then ravenously hungry because everything they just ate, now they projectile vomited. So they actually don't have those calories, and they truly, if it goes on long enough, come in truly lethargic because they're hypoglycemic. Or failure to thrive, or significantly dehydrated, depends on how much they don't have. So in every board exam I've ever taken, they give you this, so associate the hypertrophied pylorus with a palpable olive. And so if it is big enough, you really can feel this on a baby, so right where that pylorus is, kind of midline, you can feel a little, feels like kind of like an olive. That's right where that hypertrophied pylorus is. The lab that you need to know this one. So circle, highlight, star it, underline it. Hypochloremic, hypokalemic, metabolic alkalosis. That's what this lab is. Why are they hypochloremic? What are they vomiting? Hydrochloric acid. Yes. So they are vomiting up all of their chloride. Why are they metabolic alkalotic? Because they are throwing up their acid. Functionally, yes. And so that is what they're overall going to have low chloride, low potassium, and metabolic alkalosis. Is a surgeon going to touch someone who is hypochloremic, hypokalemic, metabolically alkalotic? Absolutely not. The surgeon will laugh at you, tell you to fix that, call them back when your electrolytes are okay. They will also likely have an elevated BUN that is from their dehydration, that is not from their kidneys, having taken it. Your next step then, as the primary care PA, you will order a specific pyloric ultrasound. So it is a very specific study. It's not looking at an abdominal ultrasound. It's not looking at all the different quadrants. You are literally only asking to see the pylorus of the stomach. So the pyloric ultrasound is very specific. If you did get another study, if you got a barium or if you got an upper GI series, then you would see something called the string sign. And so the string sign looks like this. So the string sign is you have all of this contrast into the stomach, and just a teeny, tiny little string of contrast can go through that majorly hypertrophied pylorus. That is what you were seeing if you got that study for an upper GI. What you're more likely to get is an X-ray of your abdomen showing a ton of air in the stomach and really nothing past that, because nothing is getting past it anywhere, much less any kind of air. If you had that specific pyloric ultrasound, you're seeing this gigantic pylorus. So what you're seeing, the S is the stomach. You're seeing this gigantically hypertrophied, kind of looks like a hot dog, and you can see it better here. So the large area is the stomach, and both sides, this is the hypertrophied pylorus. That's what is going on with the pylorus stenosis. So again, surgeon's not going to touch this until you've collected or fixed all of their electrolyte abnormalities. So first of all, you need to fix their profound dehydration, so they will get a normal saline bolus. Then you will start making sure that you are running something with D5 and KCl. So you're fixing their potassium, you're fixing their chloride, and you're fixing their alkalosis by fixing some of their dehydration and their stopping any kind of vomit. If you need to do trickle feeds, you can put an NG or OG tube and just do small amounts of trickle feeds till they're going into surgery. And then the surgery, did you guys go over this in surgery? So it's kind of an interesting surgery. The pylotomy it's functionally like a rotor-rooter. So they literally go in and they just kind of like rotor-rooter through it. And then they're like, it's done. And it doesn't hypertrophy again. So honestly, firstborn males, rotor-rooter through, we call it a day. Functionally, they open it up, go right through, and move on. And that was surgery. Just kidding. One more. Let's do this last one. So the last one, congenital diaphragmatic hernia. Another thing for embryology. So when this little baby is forming in utero, there are 4 different embryologic structures that are going to come together to make the diaphragm. So functionally, if you think north, south, east, west, they're all coming together and they're converging to make this one diaphragm. That's fine until one of them doesn't play. And so typically, one of those is called the pleural peritoneal membrane, and it's usually in that posterior lateral section that doesn't form. So everyone else came to play, those 3 sides came, that 4th side did not, and now you have an opening between the abdominal cavity and your chest cavity, where the diaphragm did not form. That's functionally what that says, if you care about the embryology. So typically, it is going to be on that left side that it didn't form, in that back posterior structure, and you will see the other parts come together, make the rest of the diaphragm, with now this just opening. What happens then is that in the rest of embryology, when the gut goes through the umbilicus, it goes out to form, it does all its twists that we'll talk about tomorrow, comes back in, and then it goes and sits back into the abdominal cavity. Well, now you have an opening, and now it can just go up into that left lateral side and take up the chest wall space. Why can it do that? Well, because the bowel develops before the lung does. And so there's functional just real estate that hasn't been developed yet. So the bowel says, might as well move on in there. And so it just takes up the room and does not then allow the lung to grow. So if your lung does not grow, it's not going to magically grow later. And that is what some of the problem with a congenital diaphragmatic hernia is the long-term hypoplastic lung. How is this baby going to present? It's going to present with bowel in the chest. So anything that you would think is going to go with a bowel in the chest is going to happen. So are you going to hear bowel sounds in that left chest? Yes, because you have bowel in the chest. Your functional amount of bowel can be up in there. And so you have this baby that will come out oftentimes looking like Hercules. So the baby has a real big chest and a real scaphoid, really skinny looking abdomen. So if you ever see the word scaphoid abdomen on a test, they're trying to tell you it's a congenital diaphragmatic hernia. They're trying to tell you that the gut is not there, it's somewhere else. It's usually up in the chest wall. X-ray will show also that there's bowel up in there as opposed to lung tissue. So that is one of the things that you see. When you have this hypoplastic lung and bowel in the chest, you need to make sure that you control the airway. So the first thing will be airway management. These children will all need intubated. They are really sick children, so they will need airway support. And then you want to decompress that. This is not the child that you're like, let's just keep feeding them, see what happens. This is one that has decompression. So anytime we say decompression, you are putting an NG or OG tube in and basically sucking all the air out. We're making sure that that bowel is as small as possible so that you don't just have a blown up balloon in this kiddo's chest. They will need a tertiary care center, so a specific pediatric surgeon to do this. And how bad this is going to be determined on how much lung formed. So do you have a functioning lung? How bad is that pulmonary hypertension? Because those vessels will clamp down if you don't have enough lung to continue to oxygenate things. And then what other organs were involved? So how big is that defect on that left side? Sometimes, and I've seen it, it's been big enough where the liver's like, hey, I think I'll go over there too. And that liver will just head off into above the diaphragm as well. So however much organs are involved, however much bowel is up there, how much lung form is going to determine that severity of that. And that's a good place to stop. We will stop there, pick it up tomorrow.